live on our YouTube platform, and they are also recorded and are available later on also. So, Dr. Shipra, the stage is yours.
And also to add, this year round, we will have a prize for the quiz, the one who gets it all right. Because I don't think we'll be stressed out too much about it, because we don't usually find somebody giving all 5 questions right. So we will give a small little token of appreciation.
All right, Dr. Shipra, you're muted actually. Dr. Shipra, you're muted, so you'll have to unmute yourself.
Yeah. Okay. Thank you so much. Thank you, Dr. Shubham. So I hope you all can see my PowerPoint presentation.
Yes, it's visible, Doctor.
Okay, thank you so much. So I'd like to thank Dr. Geeta and Dr. Anuj Khurana and others from the organizing committee for having me here for delivering this lecture today. I hope I'm able to do justice to this talk. So, just a second. Yeah, so I'd like to put this forward that there's no disclosure regarding any financial interests or conflict of interest or infringement of proprietary works of other authors. And this entire presentation is meant solely for teaching purposes. So this is the outline which was provided to me. These are the topics which I'm supposed to cover. So let's go through them one by one. The first slide is very congested, but this is just to show you all the increasing thyroid cancer incidence, especially in women, in many of these states in India. This has been taken from the latest National Cancer Registry. So what approaches your mind when a patient with thyroid swelling comes to you? So this is a WHO classification of tumors of thyroid gland. So most commonly it is adenomatous goiter or something benign and non-neoplastic. But we have a host of tumors which are possible in thyroid, ranging from the benign follicular adenoma to the recently described NIFT-P, which is non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which is a tumor with uncertain malignant potential. Then we have many malignancies, most common being papillary thyroid carcinoma. So FNAC, or fine needle aspiration cytology, is the easiest way to approach a patient, besides obviously other investigations. But this thyroid being a superficial organ, it's amenable to aspiration. So it's a cost-effective, accurate, with a low turnaround time. So FNAC is like a very good and sensitive technique for approaching these patients. So how do we approach a case once we get an FNA? So there are many ways in which a pathologist may report aspirate. But recently, very recently, but in 2007, the Bethesda system for reporting thyroid cytology was introduced. This was refined or revised in 2017. So why the Bethesda system? So the Bethesda system gives all of us a platform to be able to communicate with our clinicians in an easy way, at a common platform, as well as it also allows international communications between pathologists, between clinicians. So both TBSRTC 2007 and the latest one give us 6 diagnostic categories to classify any thyroid aspirate. Now, these categories, they have been allotted a risk of malignancy, or they have an associated risk of malignancy, which increases as we go from category 2 to category 6. As well as a management protocol has been recommended of how to manage a patient, for example, with category 2 aspirate or a patient with category 6 aspirate. We'll go through these categories one by one. So these are the 6 categories. So first, I'll come to non-diagnostic or unsatisfactory aspirate. So in order to call an aspirate unsatisfactory, we should know what are the adequacy criteria for a thyroid aspirate. So the Bethesda states minimum of 6 groups of well-visualized follicular cells, preferably on a single slide, and each group should have at least 10 cells. So when you get such an aspirate, which has mainly blood with few follicular cells obscured in blood clot, this is what we call an unsatisfactory aspirate. The risk of malignancy is 5 to 10%, and a repeat aspiration under ultrasound guidance is what the Bethesda recommends. However, there are certain exceptions to these criteria. So what are these 3 exceptions? So if on ultrasound, you have a solid nodule and the aspirate shows fewer than 6 clusters, but they are showing cytological atypia. So you don't call it category 1, you call it category 3, to which I'll come to later. If you have a solid nodule in which the aspirate shows mainly inflammation, for example, a case of lymphocytic thyroiditis with minimal or absent follicular cells, again, you don't call it category 1 or unsatisfactory, you call it category 2, which is benign. A nodule which looks like a colloid nodule on ultrasound and on aspirate, you again get abundant colloid with few or absent follicular cells. You can very well call it consistent with a colloid nodule and to correlate it with ultrasound findings. Coming to category 2, which is benign. So most of our thyroid nodules are actually benign, and these can be either an adenomatoid or a nodular goiter nodule, or it can be thyroiditis or others, for example, radiation-induced changes, etc. So these are to be followed up clinically or by ultrasound and have a low risk of malignancy. So this is a typical example of a benign aspirate. You have colloid in the background and you have these benign follicular cells. I'll take the privilege of directly jumping to the malignant category. Why? Because once we know what is category 2, that is benign, and what is category 6, that is malignant, we will be able to better understand the indeterminate or categories 3, 4, and 5. So coming to the category 6 or the malignant aspirates. These are the aspirates which have definite features of malignancy. For example, to call a case as that of papillary thyroid carcinoma, so PTC is papillary thyroid carcinoma, you need to have papillae, semoma bodies, and nuclear features, which include chromatin clearing or margination, then membrane irregularities, nuclear grooves, and pseudo inclusions. Bethesda also recommends that we give an optional note, at least in some cases of PTC. This note says that a small proportion of these cases which are actually morphologically compatible with PTC may prove to be NIFP on histopath examination. So NIFP, I had told its full form earlier, but I'll just repeat it again because it's going to come again and throughout the presentation. So NIFP stands for non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Why did they recommend that we add this optional note? So this was a study which was performed with me as a part of the Asian Thyroid Cytopathology Society, and we found, as has also been found by other international studies, that about 5% of NIFPs can be given category 6 by Bethesda, or even category 5. So this is a typical aspirate which was called malignant on FNA, or by that is category 6. So they are large papillary fragments, and the nuclear features have pseudo-inclusions as well as other diagnostic features. So now we'll go retrograde. Let's see what is SFM, or suspicious for malignancy, Bethesda 5. So when the features are not enough to give a diagnosis of category 6, that is when we call it category 5. That is, they raise a strong suspicion of malignancy, but the findings are not sufficient or enough for a conclusive diagnosis. Again, we have an optional note as advised by Bethesda over here, especially when we are suspecting a follicular variant of PTC. So this note says that the cytomorphological features are suspicious for follicular variant of papillary thyroid carcinoma or its recently described indolent counterpart, NIFP. So SFM has a risk of malignancy of 45 to 60%. Coming to category 4, or follicular neoplasm, or suspicious for follicular neoplasm. So I'd like to point out that FN or SFN, follicular neoplasm or SFN, are synonyms. So you cannot call something suspicious follicular neoplasm. These two are to be used synonymously. So typically the aspirate is cellular, and it's composed of follicular cells mostly arranged as microfollicles. There may be mild nuclear changes, but papillae and internuclear pseudo-inclusions are to be absent. Now SFN or category 4 can turn out to be a follicular adenoma, a follicular carcinoma, a follicular variant of papillary thyroid carcinoma, or NIFP on histopathology. Hence the recommendation for an optional note even for SFNs. The risk of malignancy associated with this category is 10 to 40%. So these are the aspirates which were called follicular neoplasm at our institute. So you can see these small microfollicles which are arranged back to back. They may be dispersed singly or in such trabecular pattern. Again, another arrangement or cluster of cells showing many microfollicles. There is a variant to this also, which is known as follicular neoplasm or the Hurdle cell type, in which the aspirate is again cellular. There is absent or minimal colloid, and the aspirate contains mainly Hurdle cells. So by Bethesda's category criteria, the nuclear features of PTC should be absent in these aspirates to call it follicular neoplasm Hurdle cell type. Coming to the category 3, which is AUS or FLUS, that is ATP of undetermined significance or follicular lesion of undetermined significance. These are the aspirates which contain cells. Now, these cells can be follicular, lymphoid, or other, like Hurdle cells, which show architectural and or nucleatypia, which is not sufficient to be classified as any of the higher categories. Higher means category 4, 5, or 6. So typically, risk of malignancy of these is about 6 to 18%. Repeat FNA or molecular testing or lobectomy is recommended for this group of patients. So these are 6 different aspirates, which I took out from my archives. So this is a case which showed some amount of cytological atypia. You can see some nuclear enlargement, vague nuclear grooves, elongation of the nuclei, and some metaplastic change. This is a case which was hemodiluted or diluted with blood and showed few microfollicles. This is another case in which you can see some thin colloid in the background, but the predominance of Hurdle cells, but there are also not too many of them. There are just few of them. A case which showed nuclear enlargement, some chromatin clearing, as well as some microfollicle formation, but the aspirate was of low cellularity. A case in which we saw predominance of lymphoid cells, especially of immature lymphoid cells. A case in which we saw benign looking Hurdle cells, but at the same time, there were some nondescript cells in the background, which we could not make out what are these. So these, if you see, are various, they satisfy various subcategories of category 3. So Bethesda has subcategorized category 3 into AUSC, that is cases with cytological atypia, AUSA, cases with architectural atypia in the form of tight fragments or microfollicles, cases which show both these features, AUS A and C, AUSH, in which you have some amount of Hurdle cells, but the differential diagnosis ranges from lymphocytic thyroiditis to multinodular goiter to a Hurdle cell nodule or a Hurdle cell neoplasm, AUSL, when there is some amount of lymphoid atypia, and AUS-NOS, that is not otherwise specified. So these are the 6 categories: AUSC, AUSA, AUSH, AUSC&A, AUSL, and AUS-NOS. Why this subcategorization? This was because before the latest Bethesda came in, there were some publications which showed that those AUS cases in which there was nuclear atypia, the risk of malignancy was higher than the others. So as for example, in this particular study, the risk of malignancy for AUS-C or AUS-N was 66% as compared to the rest, like AUS-A had a malignancy rate of 14%. Still, Bethesda says you have to manage all these patients. That means all these cases with these subcategories similarly. We also performed a study at our institute, and we did find a higher rate or risk of malignancy associated with AUSC. So the risk of malignancy when NIFP was not considered malignant was 50%, unlike AUSA when it was 22%. But overall, the p-value was not significant. So cases with and without cytological atypia, the difference was not significant. And that's what even Bethesda says. They say manage these patients similarly. So AUS-N, if there's a diagnosis of AUS-N, you don't go running about operating upon these patients unless and until there are other features which are indicative of surgery. Coming to the next topic. Hashimoto thyroiditis versus neoplasms with Hurdle cells. So what are Hurdle cells? Hurdle cells are actually follicular cells only, but they differ in the morphology in that they have abundant eosinophilic cytoplasm, and these can be seen and they have actually abundance of mitochondria on ultrastructural examination. And these can be seen in a plethora of diagnoses. So they can be seen in a case of adenomatous goiter, in a case of Hashimoto thyroiditis, in a case of Hurdle cell adenoma, in a case of Hurdle cell carcinoma, in a case of oncocytic PTC, in a case of tall cell variant of papillary thyroid carcinoma, in a case of Warden variant of papillary thyroid carcinoma. So they can be seen in a host of cases, and the diagnosis of an aspirate can vary from category 2 to 3 to 4 to 5 or to 6, depending upon what site of the nodule you have aspirated. For example, if a case of adenomatous goiter with Hurdle cell metaplasia is there, and you tend to happen to aspirate this colloid area, then what will you get? You will get something like abundant colloid. But if you happen to poke here, you will get a predominance of Hurdle cells. Similarly, in a case of Hashimoto thyroiditis, if you happen to needle here, you'll get a predominance of Hurdle cells. Whereas if you happen to needle here, you'll get a predominance of lymphocytes. So depending upon where you needle and how much cellularity you get, the diagnosis can vary on cytology from category 2 to 6. However, we cannot give a category of 4 if we see nuclear features of PTC. So this was a case which turned out to be Hurdle cell adenoma on dissection. This was a case which turned out to be Warden-like PTC. In fact, it's the same case which has been depicted here. And this was a case which turned out to be oncocytic PTC, the same case which has been depicted here. So we performed, as a part of the Asian thyroid cytopathology group, we performed study on all the aspirates in which a possibility of Hurdle cell neoplasm was given. And we found that categories 3, 4, and 5 predominated, and on histopathology, the diagnosis varied from Hurdle cell adenoma to follicular adenoma to even a single case of NIFP, which had oncocytic metaplasia, to all the way to many of the variants of papillary thyroid carcinoma, and even to parathyroid adenoma. So Hurdle cells on an aspirate, there's a host of differential diagnoses which you can get on histopathology. Coming to follicular adenoma versus follicular carcinoma. So when you get a follicular pattern tumor without the nuclear features of PTC, that's when you call it a follicular neoplasm. And all these cases, mind you, whether it's follicular adenoma or follicular carcinoma, will give a category, will usually be categorized 4 or follicular neoplasm on Bethesda. So when do you call a case of follicular neoplasm as carcinoma? That is, if this is the follicular neoplasm, the white central circle, and this is the blue is the capsule. So if you have this tumor penetrating the capsule through the entire thickness, that's when you call it capsular invasion. And or you have tumor cell emboli within vessels located either in the capsule or outside the capsule. That's when you call a follicular adenoma. You change the diagnosis from follicular adenoma to a follicular carcinoma. Presence of atypia and mitosis is not a very helpful diagnostic feature. So this is an image which I copied from the Bible of tumor diagnosis, Fletcher, and it's a very helpful picture for that matter. So they give this picture actually depicts when all can you call it capsular invasion. So just a bulge is not tumor invasion, capsular invasion, sorry. This is not yet. B is not yet. Not yet means you need to take serial cuts and more sections from the capsule to see whether there is actually invasion. This is budding out of tumor, and this is capsular invasion. This again is capsular invasion, and this green thing again is a secondary capsule which the tumor has formed. A nodule outside the capsule is again a capsular invasion. Tumor cells which are arranged perpendicular to the capsule, again not yet. You need to sample more. Tumor cells which are arranged parallel to the capsule is a no-no. So this is not a capsular invasion. A tumor mushrooming out through the capsule is capsular invasion. Partial mushrooming out, not yet. Sample more. This is what we typically see when there are changes secondary to aspiration. So there'll be some hemosiderin latent macrophages and vascular proliferation, and this is also not capsular invasion. Similarly, when it comes to vascular invasion, there are strict criteria. So tumor cell emboli, which are present within the vessels, but they have to be adherent to the vessel wall. Again, they are endothelialized. That is, there is an endothelial cell lining over the tumor nodule. Or even if they are not lined by endothelial cells, but they are adherent to a fibrin clot, or they are present outside the capsule in a vessel. So all these four conditions amount to vascular invasion. When they're lying loosely in a vessel without an endothelial cell lining, without a fibrin clot, and without any adhesion to the vessel wall, it is not vascular invasion. Similarly, when tumor tends to impinge on the vessels, it is not vascular invasion. So just a short quiz to you. Obviously, I'll be answering because it's a YouTube channel and I cannot actively interact with you. So there are cases to say whether it's a carcinoma or not. Well, it's not. Another case in which you can see a bulge over here, but still not follicular carcinoma yet. Both these cases are follicular adenomas. A case in which you can see vascular, you can see mushrooming out of the tumor, and this is capsular invasion. So this amounts to capsular invasion. Another case in which you can see a tumor nodule outside the capsule and a secondary capsule being formed here. Again, this is a case of capsular invasion. So follicular thyroid carcinoma has been further subcategorized by WHO into minimally invasive, when you just see capsular invasion, into encapsulated angioinvasive, when there is vascular invasion, into widely invasive, when there is extensive invasion of the thyroid and extrathyroidal soft tissues. So in this, the important point is to tell the clinician how many of the vessels, it is less than 4 or more than or equal to 4, the prognosis varies. So when the invasion is less than, when there's just capsular invasion without vascular invasion, the mortality rate is less than 5% disease, and when it is less than 4 or more than 4, it can range from 5 to 30%. Even American Thyroid Association stratifies follicular thyroid carcinoma on the basis of vascular rate of risk of recurrence is just 2 to 3% as compared to those with extensive vascular invasion when it is 30 to 55%. Okay, so I hope I'm not going too slow or too fast. It's almost 9. Okay, so ultrasound guided versus palpation guided. How do you decide whether to
You're doing very well,
Yeah.
Dr. Shipra. It's very clear. I mean, I have some questions on the chat box. I'll put them up to you later. So just continue with your presentation. Thank you.
Okay, thank you so much. So how do we decide whether the patient has to be subjected to ultrasound guidance or not while subjecting the patient to aspiration? So there are many studies, you can see over here, that FNAs performed under ultrasound guidance have lower rates of both unsatisfactory and false negative cytology as compared to palpation guided procedures. But mind you, it actually depends a lot upon the expertise of the person who is doing it. So if you have a good ultrasonologist who has a good capability of aspiration, he'll do a great job. But if he's not good enough or a fresher, he may or may not do a good job. But overall, ultrasound guided aspirates have definitely a lower rate of both unsatisfactory and false negative cytology. So as per ATA 2015 or American Thyroid Association guidelines, recommendation 7, this states that for nodules with a higher likelihood of either a non-diagnostic cytology, which they have described as more than 25 to 50% cystic component, or a sampling error, that is a nodule which is difficult to palpate or is posteriorly located, ultrasound guided FNA is preferred. It's also preferred when you have an initial unsatisfactory aspirate, as well as when the nodule is subcentimetric, or in case of cervical lymph nodes, both these showing ultrasound features suspicious for thyroid cancer. Now, I'm not going into the ultrasound features of it. I think a radiologist will do a better job on this, although I do have a slide on that, which is hidden. So, but I'm not going into the details of this. So coming to the next topic, how do we decide whether or not we need intraoperative frozen section? So if I ask you, as a clinician, why do you need frozen section for thyroid tumor diagnosis? So, or management. So maybe these are the things you'll give me, you'll tell me, to confirm presence or absence of malignancy, especially in indeterminate Bethesda category aspirates, to decide upon the extent of surgery, if malignancy is confirmed on intraoperative frozen section, and histological subtyping of thyroid malignancies. So let's go through the literature and then decide. So this was an article by Dr. Trossman, and he said that of the 29 patients with a negative report on intraoperative frozen section, 34% or 10 cases were diagnosed with carcinoma on follow-up histological examination. Hence, he concluded that while intraoperative frozen sections on thyroid specimens may be helpful if positive, the false negative rate remains high. Another study published in 2017, which showed that the intraoperative frozen sections are futile in the evaluation of follicular thyroid lesions. So this is a literature review done by Bollig et al. In 2018, this was published. So they showed that of the study, in all the studies which were published evaluating utility of frozen section in thyroid, as many as this is a wide range ranging from 19% to 97%. 19 to 97%, in 19 to 97% cases, the diagnosis was deferred to paraffin section. So they could not actually give a final diagnosis or a final impression on frozen section. The percentage of cases in which the operative management was altered ranged from just 0 to 7%, or sorry, 8%. And thus, most of the authors concluded that frozen section in case of thyroid, especially follicular origin lesions, has minimal or no value. However, there are two studies by Bollig et al. Again, in which they have shown that intraoperative frozen section has utility in large thyroid nodule. By large thyroid nodule, they meant a nodule which is more than 4 centimeter in size. Utility in the sense of cost cutting. So additional cost savings could be obtained if intraoperative frozen section is avoided among patients with follicular lesions. Similarly, they showed economic impact of frozen section in nodules which were suspicious for malignancy. So I'd also like to put forward what ATA says for this. So they say intraoperative evaluation with or without frozen section can occasionally confirm malignancy at the time of lobectomy, allowing for conversion to total thyroidectomy if indicated. So what they mean by this is, if we confirm malignancy at the time of frozen, the clinician can convert lobectomy to total. I'll come discuss this point later. Another thing they say is frozen section is most helpful if the histopath diagnosis is classical PTC, whereas its impact is low in follicular variant of papillary thyroid carcinoma and in follicular thyroid carcinoma. So just keep these two points in mind. We'll discuss them soon. I'd also like to point out the recommendation 35. So it says thyroid lobectomy alone may be sufficient as an initial treatment for low risk differentiated thyroid carcinomas, that is nodules which are sized between 1 and 4 centimeter, lag extrathyroidal extension, and nodal or distant metastasis. So what do you mean by this? So if there is a large nodule which is more than 4 centimeter in size, and you confirm presence of a papillary thyroid carcinoma on frozen, that's when you can subject the patient to total. But those cancers which are which are less than 4 centimeter and they lack any of the aggressive pathological features, they can just be treated with lobectomy. So actually in those patients, there won't be any utility for performing a frozen section. So from this, I concluded that this is a general conclusion for all frozen sections. Morphology is better preserved on fixed tissue than on frozen tissue. Hence, more chance of an inconclusive diagnosis on frozen section. Frozen section has more utility in classical PTC for confirming diagnosis. There is little relevance for frozen section in follicular variant of papillary thyroid carcinoma and in follicular thyroid carcinoma. As in both these conditions, capsular and or vascular invasion is needed for calling it a carcinoma, and that may not be demonstrated, and that's difficult to demonstrate on frozen. It's sometimes very difficult to demonstrate even on histopathology. Considering lobectomy as the current recommended management protocol in a large subset of thyroid cancers, the number of cases in which intraoperative frozen section would actually impact surgical management is probably small. So that's the end of it. These are my reading recommendations. Thank you.
Thank you. Thank you, Dr. Shipra. Now, it was a very concise presentation, and I must say that you speak at a good speed, and we could.
I know, I'm very fast.
I'm so happy that it's recorded, because I will need to go it through, and especially the slides. You know, we as surgeons, and I'm sure a couple of people that I know on the group will not be so fluent with the microscopy, so we were not able to. But the good thing was that there were slides, so many slides, so probably next time that we go over it, we might be able to differentiate. So there was this question on the chat box. I'll just read out that question to you, and then I'll take on some of the other questions that are there. So what are papillary-like nuclear features? Are they just similar to the orphan eye nuclei that we see, or there is something other than the papillary-like nuclear features? So what do we mean by the term papillary-like nuclear features?
So papillary-like nuclear features, the person has very well put it, they are often any nuclei. So I actually enumerated them. Maybe I was not clear. So chromatin margination, chromatin clearing, grooving, membrane irregularities, pseudo-inclusions, enlargement, nuclear elongation, all these amount to papillary-like nuclear features.
Okay. So we just talk about the orphan eye nucleus, and this is what we know because of the MCQs that they come often, but this is what the nuclear feature means. And also, could you elaborate on the FVPTC, the follicular variant of the papillary thyroid that we come across? And this is usually a post-op histopath report that we actually come across. It's not very frequently that we see this on a on a diagnostic FNAC that we come across.
So I can actually just take 1 hour lecture on FEPTC. It's not as okay, but just to tell you in concise, from a clinician's perspective, so it's just a variant of papillary thyroid carcinoma. Nuclear features are retained, but instead of showing papillae, which we see in a classical PTC, FEPTC shows predominantly a follicular pattern. I should not say predominantly. The latest criteria say that true papillae should not be present, especially in NIFT-P. So NIFT-P, okay, so how should I go about it? Okay, so NIFT-P is the indolent tumor. Like follicular carcinoma, we call something follicular carcinoma when there is capsular or vascular invasion. Same way, when a case which is follicular patterned has nuclear features of PTC and it shows infiltrative characteristics, either in the form of invasion of the adjoining thyroid parenchyma or in the form of capsular or vascular invasion, the way follicular carcinoma shows, that's when we call it follicular variant of papillary thyroid carcinoma. Clinical outcome-wise, its outcome is similar to classical PTC, but it tends to have hematogenous metastasis more frequently than classical PTC.
Okay. So it's the nucleus features would be more of a papillary variant, but the pathologically you will see not the papillary variant, but you will see more of the follicular features. That just to
no, it's just the architecture which is different. So you will get the cells are arranged in a different architecture, like the way you see normal thyroid. It's arranged in follicles. So in FEPTC also you see a follicular arrangement of the cells. So they have colloid in the center, a lumen in the center with colloid surrounded by a ring of cells.
Okay. So Dr. Noor Mohammed has asked that, do you do a thyroglobulin washout? And can you tell us the technique? So as a surgeon, I would want to know what is thyroglobulin washout actually to begin with.
Okay, so we don't do it here, but I know what is it. So when you aspirate a thyroid nodule or a suspicious lymph node, so you can send the aspirate for doing thyroglobulin levels. So if it's less than 1 nanogram per ml, I think that's the cutoff. So if it's that less than that, then you are safe. Okay, it's not a case of PTC or a thyroid carcinoma metastasis. But if it's more than that, then that's what it means, that it is likely to be a case of metastatic disease. Or if it's from the thyroid, no, it's actually mainly used in lymph node aspirates to see whether there's increased thyroglobulin levels or not in that particular aspirate. So if it's more than 1 nanogram per ml, it indicates that there is metastasis.
Okay, so which actually brought me to a question that many times you decide malignancy not by the thyroid FNAC, but you get a FNAC from the lymph node which might be enlarged. So is it sufficient to say that if a thyroid tissue is seen within those lymph nodes that it would be malignant, or could there be non-malignant variants where the thyroid might be deposited within the lymph nodes?
Okay, so we have come across one such case in which lymph node had thyroid tissue, but on thyroidectomy, there was no focus of papillary thyroid carcinoma despite whole processing the specimen. So actually, in older times, they used to say that this is ectopic thyroid, but now for all practical purposes, it is called a metastatic thyroid disease.
Okay, so we'll treat it like metastatic. Okay.
Yes. Yes.
Okay, next question. Do you use ROSE at your ultrasound sites? If you were to do FNAC or ultrasound guided FNAC, would you use rapid onset evaluation?
So we are using it regularly.
Okay.
It ROSE for all our ultrasound guided aspirates, even if non-thyroid.
Oh, okay. And does the Bethesda apply at that point only, where you look at 6 follicles, or you later evaluate whether it is sufficient for Bethesda or not?
So we look at that point itself, whether we have adequate cellularity or not. If we don't have adequate cellularity, we ask them to take another pass.
Okay. Okay. Now, the next question is that when we do ultrasound guided FNAC, many times we come with large nodules which are actually clinically palpable. So would you suggest even in those, should we go for an ultrasound guided one, or should we go with a on table, not on table, but
palpation guided.
Palpable guided? Yeah.
So actually it depends upon the expertise, as I told you, and the nature of the swelling. So I personally prefer to do it myself. I do the needling myself, unless and until I know by ultrasound it has a major cystic component, when I may not get anything and I need to do it under ultrasound guidance to look for the solid component. So if it's easily palpable, better to try it yourself. So sometimes even the swelling collapses, especially thyroid aspirates, they'll collapse completely. So what we do is, after aspirating it entirely, after evacuating the entire fluid, we process that also separately. Plus we needle the swelling again for any separate or any residual, or for getting the cellularity from the wall of the nodule.
Okay. And the aspirate that we aspirate, the fluid that we aspirate, do we send it for some particular test, or that is not required?
So I told you, so if we get a fluid, so we can cytospin it and prepare smears, as well as we can make direct smears if it's thick enough. Otherwise, we prefer cytospin. We spin it down so that it's like a centrifuge. You spin it down and you get a layered cell layer on a slide.
Okay. Now, if it's a solid palpable nodule, would you still want to go for a FNAC, or would you then prefer a true cut biopsy? Because if it's a big nodule, you can actually go for a true cut nodule, but we see always the cytology being preferred, not because it's more common for thyroid than the pathology.
So I will prefer a FNAC. It's non-invasive. You don't need to anesthetize the patient. You don't need to do anything. So I'll prefer.
I meant a true cut. I meant a true cut. Where you don't need to anesthetize.
Okay, you meant a true cut.
True cut, yeah.
I will still prefer a FNAC. We have seen true cuts, but so many times there was one case of true cut, I still remember. Morphologically, it was looking benign to me. It was looking adenomatous to me, but on dissection, it turned out to be follicular carcinoma. So the entire tumor was just like a follicular neoplasm, and the area which the clinician had sent was from the center of the nodule. So the center of the nodule was like just follicles, and obviously we could not assess capsular invasion or vascular invasion on that central part. FNAC of that would have given a diagnosis of follicular neoplasm, But still, I will prefer a case it to be called as, I will prefer it to be called as a follicular neoplasm. Means I'm sorry, I will prefer a FNAC to that.
FNAC to that. Okay. And is there any role of IHC in thyroid? Again, Dr. Noor Mohammed has put this question. Role of IHC in thyroid?
So there are so many publications on IHC in thyroid, but none has a conclusive, there's no single definite marker on IHC. I hope there was. It would have made my life easier. So there's nothing which is definitely diagnostic. There are multiple markers like HbME1, CK19. We keep on trying all of them, but ultimately it comes down to morphology in thyroid.
Morphology.
Certain cases like medullary thyroid carcinoma, when calcitonin can help. Anaplastic thyroid carcinoma is also morphological diagnosis, PTC. Mainly the problem is between follicular FEPTC, NIFT-P, and follicular adenoma or carcinoma. So these are the main problem zones which stay a problem despite IHC.
Okay, and just a last question before we let you go. I'm sure everybody is itching to get the heat of Lodi. But if you're suspecting anaplastic, would you still prefer a FNAC? Because I know for sure that the amount of tissue is not sufficient for a FNAC for a anaplastic, and would you not prefer then a biopsy?
No, FNAC is good enough.
FNAC is good enough?
Yes, FNAC is good enough.
Okay. So
you can biopsy if you want to do BRAF mutation or BRAF IHC, but not morphological diagnosis. Even on cyto, we can do BRAF molecular. Molecular can be done on cytology also. If you just say diagnosis, I just need diagnosis. FNAC is good enough. Why should I subject the patient to TrueCut if I can do it on FNA? That's my take.
All right, Dr. Shipra, and this justifies why you are the perfect speaker to speak on the cytology, because we sometimes I feel that the pathologist requires more tissue, especially in for anaplastic, where it just comes as it begins with poorly differentiated, and then we are tempted to think clinically that could it be anaplastic, but this is what our challenge as oncologists is. So I think that is the questions that we have. Thank you, Dr. Shipra. I don't want to keep you away from Lodi. We had a very concise lecture, and we will continue our series with thyroid. You want to say something, Dr. Shipra?
No. Thank you so much.
Okay. Thank you, Dr. Shipra. Thank you so much. And we hope that we did not intrude in your evening too much, but we purposefully keep it at 8:30 so that a lot of residents can attend it. And I'm telling you, the 30 people who actually attended it would be benefited the most, and it stays online for us to refer back. And believe me, I am the person who refers back most to it, because now I know where to look for the correct matter if I need to go back to. So thank you so much, Dr. Shipra. And we continue with the thyroid saga next time, with moving on to the surgical part, and we'll talk about the different type of surgeries available, which surgery to choose when, and what should be the extent of surgery now that we are enlightened by Dr. Shipra about the pathology.
So thank you so much. I hope I really enlightened you all.
It was enlightening. Dr. Geeta, last words.
So I think, we've made a good start to this new set of lectures that we're going to have this month, and you've set the ball rolling in right earnest. And I'm sure this is very, very complex, but I think you've made it very simple, because I also sat through it, although thyroid is not my area of interest. I'm an exclusive breast person, but I sat through this.
Now I'm going to talk to my pathologist. Why do they insist on a biopsy for anaplastic? I get most trouble with the anaplastic variety every time. So now I
think the quality of cytopathologists is also important, isn't it?
That is the reason.
So you can start sending it across to me.
So now you know where to send your, FNACs.
Thank you, Dr. Shipra.
Thank you so much, Dr. Shipra.
Okay, thank you.
And, you did a great job. I must say that you did a great job. Sometimes, it comes very easily to you because you do it every day. But, if Shubham and I are a little foxed, it is because we probably don't understand it the way you understand it. But I'm sure Yeah,
I
you've
had
done a
tried to
great job.
simplify it as much as possible.
No, you have, and I think you did a great job of it. And I can see that you understand it very well. You obviously have a great handle on the subject. And of course, we will always go back, and we have that the liberty to go back and see what you have said, and make more meaning out of it. I'm sure all those who attended, I'm sure a lot of pathologists were there, because I saw a new bunch of
Yes.
attendees today. So I think they were mostly pathologists in training, which is so wonderful. And I'm sure they would have all benefited from your talk. Thank you so much for taking time out for this.
Thank you, everybody. Good night.
Thank
See
you,
next
thank you,
week.
Dr. Geeta. Thank you.
Thank you.
Good night. Thank you.
Good night.